Yes, so good afternoon, doctors. We are live now. We can initiate.
Yeah. Hello, good evening, all. Good evening, respected faculties. So, this is again another interesting webinar from IFS Chhattisgarh chapter in association with ROGS on reproductive immunology. And we are very glad to welcome our esteemed speakers from Mumbai, Dr. Mohan sir and Dr. Mugdha Raut. I welcome all of you, all the seniors from Chhattisgarh chapter and ROGS chapter, IFS and ROGS. So today's discussion will be very mind blowing. I suppose that it will be a very much innovative things what we can do for our patients of recurrent implantation failure and recurrent pregnancy losses. Because in OPD, when we see that the patients are getting repeatedly miscarriages or they are not the urine pregnancy test and beta hCGs are very negative, so it's very disheartening. So what else can we do for them? So today we will see what can be done in future for the patients like this. And today I like to invite Anuradha ma'am to have to say some few words.
Thank you. Thank you. Good evening, everyone. First of all, a warm welcome to Dr. Mohan Rao sir and Mugdha ma'am. It was my dream to listen from him, and in fact, physically, I have told previously, but now today, anyhow, we got him, and I feel after listening him, we can treat our patient recurrent pregnancy loss or implantation failure patients, and we can tackle them properly. If required, we can have the communication and advice from them also. And I want to thank Dr. Pankaj sir and Shweta ma'am to give us this opportunity to organize such type of CMEs. And I thank Mohan Rao sir also and Mugdha ma'am also to accept our invitation and taking out some time and to share their practical knowledge, because they are the legend from this part, and they will share the practical things what we can do here, and when we have to refer the patients to them, how much we can do our level. That is very very important for us to know and treat these patients. Thank you sir, thank you for, again, for accepting, and we can go ahead with the talk now.
So
Dr. Pooja,
for the
you.
first session, I would like to invite our chairpersons, Dr. Monica Pathak ma'am. She is the esteemed senior gynecologist from Raipur, and Dr. Swati Mohabia madam. She is also a senior gynecologist from Raipur. Dr. Ritu Jain. She is a consultant director of Mahavir Hospital from Raipur, and Dr. Sanchita Pal. She is also from Raipur. So I welcome Mugdha ma'am. Her topic will be on dysbiosis in reproductive immunology. So as we already know that fetus is a semi-allogenic graft. मैम आपका म्यूट करेंगे क्या? सुषमा मैम and अनुराधा मैम. So, as we already know that fetus is a semi-allogenic graft which has to be taken up by mother, and so many factors they play a role in immunomodulation. When we read about this, uterine natural killer cells, macrophages, immunomodulation, and there are so many cytokines, interleukins, and all TNF. So it becomes very complicated what exactly can be done for these patients, and I invite Mugdha ma'am to throw some light on this topic. Welcome you, ma'am.
Thank you so much, Pooja ma'am. I'll start with my screen sharing.
Yeah, please, ma'am.
So, my topic today is, at the beginning, I would like to thank Dr. Pankaj Talwar sir, Dr. Monica Pathak, who is the president of ROGS, and Dr. Anuradha Tibrewal for inviting us for this seminar on a topic which is something really close to our heart on reproductive immunology. So we have divided our talks into, which you all know, into 4 parts. I will be starting with the first part called dysfunctional immune response and its effect on implantation and fertility. And we are going to try how we can bridge the gap between the immune system and reproductive failures.
Yeah, it's visible, ma'am.
Yeah. It was not going forward. Yeah. So I'm Dr. Mugdha Raut. I'm a practicing gynecologist. I'm rather a gynecologist, not practicing gynecology anymore, and a clinical reproductive immunologist. My husband and me are both fellows of the American Society in Clinical Reproductive Immunology. We are the only 2 ones in India out of the 43 worldwide. And we don't do IVF, we only do clinical reproductive immunology. We have 7 centers in India, and rather 6 are already functional. The 7th one will be starting in Chandigarh soon. So to begin with, a very profound statement by Bob Wright is that no doctor has ever healed anyone of anything. And it is actually the human immune system that heals. And that's the only thing that heals. So let me start with a very interesting story of Shawly and Benny. This couple is an Indian origin couple in Ireland. They found us on the internet and they sent us an email. And Shawly had suffered from 15 miscarriages. 8 were spontaneous pregnancies, 7 were IVF pregnancies, and additionally, she had 4 more IVF failures. She came to India, we did her tests, and what happens, we will tell you at the end of the talk. So what is the scope of our talk today? First is what is reproductive failures, why immunotherapy, when and how immunotherapy, and Immulate, which is our patented and branded process based on lymphocyte immunization therapy. Now, according to this journal, this paper published in the Austrian Journal of Reproductive Immunology, RPL and infertility should now be treated as 2 sides of the same coin. It is a time for us to think and change. Now, why is it so? Because it is not only the desire of a couple, but it is also because they share the common etiologies, diagnosis, and the treatments, which are both there in RPL and infertility. So then what is reproductive failure? Reproductive failure is now clubbed into biochemical pregnancies, repeated miscarriages, IVF failures. And I'm not going to go into all the details. We all know the causes of either miscarriages or IVF failures. But in 50 to 60% of these couples, all these factors are normal. And they are called as unexplained repeated reproductive failures. And these couples are handed over to nature. And in these so-called unexplained cases, the cause could be immunological. And immunological factors can also coexist with other causes of reproductive failures. Now let us see the overview of repeated pregnancy loss. According to ASRM and ISHRE now, it is defined as 2 or more pregnancy losses. And according to ASRM and ISHRE, the prevalence is only 1 to 2%. But let's see what's the problem in India. This is the report by the Ministry of Statistics and Program Implementation in 2017. And where they found that the number of couples with wife in the bearing age group is 170 per 1,000 population. So total couples with wife in the childbearing age group is 213 millions. If you consider the incidence of RPL to be 2%, we have 4.25 million couples who have RPL. And if you consider 5%, it is 10.6 million. And 50% of these cases are unexplained. So we are having currently 2 to 5 million couples facing unexplained repeated pregnancy loss. Now let us look at recurrent implantation failure. Again, it is an enigma. Now, according to this report, the IVF success rate for women doing their first cycle, if they are less than 35, it is 55.1%. 35 to 37 is 40.5%. And as the age increases, the success of an IVF to give a live birth definitely decreases, being only 8.2% more than 40 years. So what is recurrent implantation failure? You all know it. I'm not going to go into the definition, but it is estimated that approximately 10% of women seeking IVF treatment will experience this particular problem. Okay, so we say 10% of the women. But you will agree with me that implantation is an inefficient process. And actually, the maximum implantation rate in any woman would be only 40 to 60%. And as I told you, the implantation rate in IVF less than 35 years is 37%, 35 to 37 years is 30%, and at 41 to 42% years, it is only 12%. The implantation failure in ART is thus 40 to 60%. Now, again, the factors we all know, I'm not going to go into the detail. But what is the prognosis for a live birth after unexplained recurrent implantation failure following IVF and ICSI? There is a very interesting study by Coop where he surveyed 118 patients with RIF defined by failure to conceive after 3 embryo transfers, found that only 49% of the respondents ultimately achieved a live birth in a 5.5-year follow-up period. So this indicated that approximately 50% of RIF patients may ultimately not complete their family goals. So now let's see why immunotherapy. We say that pregnancy is nature's most successful transplant. But today I am going to talk completely contrary. Pregnancy should not be accepted by the body, but somehow it does. And why does it do it? It is because the pregnancy, we say, enjoys a special immunological status or immune tolerance. And what happens if this natural tolerance fails? That's where reproductive immunology and all our treatments and investigations begin. Now, what is reproductive immunology? Reproductive immunology explores the immune system's role in implantation and pregnancy. And we all know this. A balanced immune response, a Th1, Th2 response ensures tolerance to the fetus and a healthy pregnancy. Now, why does it matter? It matters because many cases labeled as unexplained reproductive failures could be having an immunological basis, which would probably remove a part of the term of unexplained repeated reproductive failures. Now, in 1953, Sir Peter Medawar, who is considered to be the father of reproductive immunology, and he got a Nobel laureate for progesterone, he asked, how does a pregnant mother manage to nourish within herself for many weeks and months a fetus that is an antigenically foreign body? This was way back in 1953. Because we all know that our immune system is our body's protection against any invader. And yet, this powerful defense system is overcome in pregnancy in mammals, where the fetus grows in the mother's body. This is what we study as viviparity. So, maternal immune tolerance is very critical to the fetus, and any immune dysregulation can lead to fetal rejection. We all know that the fetus is a semi-allograft. The embryo and gestational tissues express foreign antigens derived from a different maternal and paternal chromosomes. Now, this is where you're using self-eggs. If you're using donor eggs, it is going to have completely 100% different MHC genes. So otherwise, when you're using self-eggs, because the fetus expresses different MHC genes, the fetus is termed as a semi-allograft or an allograft. So there is a critical requirement for circumventing or bypassing the immune system. And here we have to understand that reproductive immunology is different from transplant immunology. In any kind of transplants which we hear, like a kidney transplant or a liver transplant, we have to match the donor with the recipient. Pregnancy is the only condition which actually shows that even if they are not matched, it will be accepted by the mother's body. So according to Sarah Robertson, who is a world-renowned researcher in reproductive immunology from Australia, she says pregnancy is the test of the fundamental laws of transplantational immunology, where genetically different tissues coexist without host immune rejection, which is never seen in any other organ transplants. And the immunological equilibrium, that is balancing lymphocyte activation and control, is very, very important. Activation is where there is reaction against pathogens, and tolerance or regulation shows that there is no response to self and other harmless antigens. So tolerance is only towards three things in the body by birth: is self-tissue, commensal bacteria, and pregnancy alloantigens. Now, how does allorecognition, what happens when allorecognition is going to happen? The decidua along with the peripheral blood and the T regulatory cells cause a Th2 response, which along with interleukin 4, interleukin 10 and interleukin 13 cause a facilitation reaction. There are blocking antibodies produced and there is protection of pregnancy. On the other hand, the trophoblast produces the HCG, which helps in production of progesterone and progesterone-induced blocking factor. Again, the Treg cells come there to help, and there is local immunosuppression. Now, what happens when allorecognition is not going to happen? That is when rejection is going to happen. There is failure of allorecognition. The decidua in the peripheral blood bring in the Th17 cells. There is Th1 response. TNF alpha, interleukin 2 and interferon gamma act. There is rejection reaction. No blocking antibodies are produced. There is destruction of pregnancy. On the other hand, the trophoblast usually produces low HCG, low progesterone, low PIBF, and there is no local immunosuppression causing destruction of pregnancy or failure of implantation. So if you can see from the two diagrams before, the T regulatory cells have emerged as central players. We all know that pregnancy, the implantation process does require an inflammatory response in the initial stage. A Th1 response is required for trophoblast invasion, tissue remodeling, and angiogenesis. But remember, this is controlled by the T regulatory cells. If it cannot control, it results in unregulated Th1 response during the actual trophoblast invasion. And then the T regulatory cells also help to protect the promote allograft rejection. Allograft tolerance. So what are T regulatory cells? They are specialized immune cells that suppress the harmful immune responses. They help in maintaining tolerance towards the developing embryo. And any dysfunction in the T regulatory cells can lead to implantation failure or miscarriages. So what are T cells, T lymphocytes? T lymphocytes are broadly categorized into CD8 and CD4 T cells. What we require in pregnancy are the CD4 T cells, which are of 4 types. 2 are inflammatory, that is Th1 and Th17. Th1 produces inflammatory cytokines and Th17 produces pro-inflammatory cytokines, affect the pathogens and can also cause graft rejection. The 2 types of anti-inflammatory are the Th2 cells, which promote produce anti-inflammatory cytokines. They promote B cell development. And the T regulatory cells, as I said before, are the most important one. They are immune suppressive. There are 2 types, natural Treg cells which come from the thymus and the inducible Treg cells, which are most important in pregnancy, which are produced in the decidual tissue and help in causing immune tolerance to the response to the embryo, the sperm and the oocyte. So whenever we are doing immunomodulation, we are preferably trying to convert the inflammatory response to the anti-inflammatory response. Now, at what levels can an immunological attack happen? It can happen at ovulation or recovery of the eggs when the TNF-alpha can damage the DNA in the eggs by apoptosis, spot welding happens, and the DNA which is formed is not as good as the natural DNA, and that causes poor oocyte quality. So the embryo either shows slow division, cellular division, fragmentation of the cells. It can cause inclusion in the cells, and this causes failed IVF, implantation failure, and even ovarian failure. Now, if there is attack before implantation, the TNF-alpha and the natural killer cells which are in the uterus, they cause apoptosis of the DNA in the embryo, leading to spot welding again of the DNA. So the embryo grows slowly, dies, or embryo never attaches itself. Sometimes you only see the placenta which is growing and the embryo is not seen. And after implantation, if the immunological attack happens, there could be decidual necrosis, subchorionic hemorrhage, placental cell death, yolk sac damage, slow heartbeat, irregular shaped gestational sac, and too little amniotic fluid. So, this is what I wanted to tell you initially. Now, how will we identify that this problem exists? How to diagnose it? I will be handing over to Dr. Mohan Raut.
Questions? Have you planned any questions? Should we go ahead?
Yeah. Should we go ahead or you all have planned any questions?
No, ma'am. No, ma'am. We should go ahead. We should
Okay.
go ahead.
Yeah, so I'll just hand it.
Questions will be last.
Okay.
So everything.
Yeah.
Hello, everyone. I think you can hear me, see me, right?
Yes. Yes, sir.
So I am also thankful to you all for the invitation. And as Madam has already mentioned at the beginning, so we will go ahead with the flow, because the first part, Dr. Mugdha told a little bit about reproductive immunology, what happens at the time of implantation, and later on during the pregnancy, what immunological changes happen. So you must have seen that the 3 important aspects which play a major role in the growth of pregnancy, or in pregnancy, you can say. One is related to the antibodies, second is related to the immune cells, and third is related to the immune cytokines. So these are the 3 parts which are active in protecting pregnancy, and if they don't function properly, there will be loss of pregnancy. So when we want to diagnose this immunological factor in recurrent pregnancy loss or recurrent implantation failure, our focus will naturally be to find out if there are any problems in these three parts of the immune system related to the protective antibodies, related to the immune cells and immune cytokines. So in my talk today, I will be talking about when and how immunomodulation can be done, and so in how we can select couples who will be benefited by the reproductive immunology treatment and what we can do for them. Okay, so as I mentioned that to know whether a particular reproductive failure is because of immunological factor, we take help of certain investigations. Now, these investigations are again based on these three factors which I have told you: antibodies, cells, and cytokines. So who needs basically immunological testing? Patient who has recurrent pregnancy loss, that is 2 or more miscarriages, especially those the other investigations which are responsible, tests or the conditions responsible for repeated miscarriages are normal, but in spite of finding a known cause, the immunological factor can coexist. So therefore, any patient with 2 or more miscarriages, we must keep in mind immunological factor. Repeated IVF failures, 2, 3, that will depend on the treating doctor because each patient is different. A patient who is elderly with low AMH, you may not want to wait for more cycles to fail or miscarriages to happen. Unexplained infertility where no cause is found after the standard investigations. Even second or third third trimester losses have alloimmune factor as a basis, and especially those patients with early onset preeclampsia are classical patients with problem of alloimmune system, and they can be helped by immunomodulatory treatment. Patients with endometriosis, adenomyosis, they are always associated with immunological problems, and in these cases alloimmune problems coexist. And the last group is raised antithyroid antibody patients, anti-TPO and anti-thyroglobulin. So what we do at our centers is a detailed immunological testing related to these conditions, and then we offer the immunological treatment of active immunomodulation, that is Imulit, which is, as Dr. Mugdha said, a patented process of lymphocyte immunization therapy, followed by immunomodulatory medications, and we work on with the doctors who are treating actually the patient. So I will be talking on everything of this except lymphocyte immunization therapy or Imulit, which Dr. Mugdha will cover in the next part. So the diagnostic tools for alloimmune factor, there is a big list of investigations. If you go abroad to US and to go to a reproductive immunology lab, they will give a list of investigations costing maybe 4 to 5 lakhs of rupees. But I have made a list of these investigations like lymphocyte cross-match, also called as the LAD test, or leukocyte antibody detection test, peripheral blood NK cells, complete assay and NK cell inhibition panel, uterine NK cells, serum TNF-alpha, and various cytokine ratios like TNF-alpha IL-10 ratio, T regulatory cell estimation, and TH1 TH2 cytokine ratio. So these will help, as I mentioned, to know about we will go into the details of these tests, but the investigations of these which we use and which are easily available in our country are lymphocyte cross-match, NK cells in the peripheral blood, and NK cells in the endometrium, serum TNF-alpha, anti-thyroid antibodies, and additionally we do certain tests which are otherwise common investigations, but they have a role on the implantation process, and they affect the immunological part of implantation process, that is HbA1c, lipid profile, and serum homocysteine. So let's come to the first test, lymphocyte antibody detection test. Now this is the gold standard to know about the alloimmune problem. What this test does, this is a test done with husband and wife's blood together, and it helps to know the presence of protective antibodies or blocking antibodies. Now, the concept here is pregnancy is protected by certain type of protective antibodies. They are also called as asymmetric antibodies or blocking antibodies, and they help to protect the pregnancy, and these antibodies are naturally formed. Maybe one of the important mechanisms is exposure to seminal plasma, which contains certain chemicals which stimulate mother's immune system to produce T and B memory cells, which later on produce protective antibodies and T regulatory cells when they are exposed to pregnancy. So, and this occurs naturally. So, we can estimate whether these protective antibodies are there or not in a patient who have unexplained repeated miscarriages or recurrent IVF failures. And as mentioned here, it measures the amount of antibody that reacts with proteins of paternal lymphocytes. Now, these asymmetric antibodies are very typical in the sense that you know that antibody has a Y-shaped structure. So there are two arms, while these asymmetric antibodies have only one arm. So the typical antibody attaches to pregnancy with one arm, and the other arm attaches to the activates the complement system, and that leads to destruction of pregnancy. While here, these antibodies have only one arm which attach to the pregnancy, and they can't trigger complement, so they competitively inhibit those antibodies which otherwise destroy pregnancy by default, and this way pregnancy is naturally protected. And if these protective antibodies are not there in a couple who has, say, multiple unexplained miscarriages or IVF failures, where the cross-match report comes negative, then these patients will benefit by immunomodulatory treatment that will help induce these protective antibodies. So that is LAD test or lymphocyte cross-match. The endometrial natural killer cells. Now, NK cells are naturally or normally present in the uterine lining, and they play a very important role in implantation and maintenance of early pregnancy, as Dr. Mukta told you. But excess concentration of uterine NK cells is not good, and they have been associated with recurrent miscarriages or implantation failures. So the type of cells, NK cells in the endometrium, they are also called as CD56 dim cells, which are normally present, and if they are very high, they maturate or they get converted into CD57 type of cells. Now they are CD57 are normally not present in endometrium. If they are highly cytotoxic and they are detrimental to pregnancy, and they can cause recurrent pregnancy loss or miscarriages. So if we find out CD57 in the endometrial lining, then that patient will definitely require immunomodulatory treatment, which will benefit in helping or preventing RPL or RIF. How will we find that? So there's a simple test. You can do an endometrial biopsy in the luteal phase, say between 19th to 23rd day of the cycle, or even later on first day of the periods also, as we do endometrial biopsy. And the endometrium is collected in formalin and sent for immunohistochemistry. And presence of CD57 type of cells is an indication of immunological problem or alloimmune problem, because they are normally not present. And many standard labs do this test, including Metropolis lab, and it's not a very expensive investigation. So this has been confirmed by different studies, and this is one interesting study which has compared the ratio of CD57 to CD56 in women who have recurrent implantation failure, and they have shown that this ratio increases. So in patients who have RIF, so this can be used as a parameter to find out whether there are chances of recurrent implantation failure due to immunological factor. The next is the TNF alpha. This is the inflammatory cytokine, and TNF alpha is normally present in our body, but if the levels are high without any apparent reason, that is not good for pregnancy. It can cause miscarriages, it can cause recurrent implantation failures or IVF failures, and it is very commonly seen in patients who have recurrent implantation failure. The TNF alpha levels are invariably high, and they require immunomodulatory treatment for successful pregnancy. The antithyroid antibodies, yes, they are also play, because antithyroid antibodies are always associated with poor ART outcome or pregnancy outcome. Why? It is important to know that you will be surprised to know that almost 80% of patients with raised antithyroid antibody are euthyroid. So that therefore a euthyroid patient doesn't mean antithyroid antibodies are normal. So in all patients with reproductive failures, it is mandatory to do the antithyroid antibody test, because isolated thyroid antibodies without abnormal thyroid function are also known to be associated with reproductive failure, and the chances of reproductive failure or miscarriage is 3 to 5 times more in patients who have raised antithyroid antibodies. And women with thyroid autoimmune disease may easily develop thyroid dysfunction during the ART cycle and in subsequent pregnancy, and that can lead to infertility or even pregnancy comorbidity. So basically, many patients who have normal TSH levels can have these antibodies and responsible for pregnancy dysfunction. And therefore, now you may ask why, how that is important, because our endocrinology friends, endocrinologists always tell us that these antibodies don't require treatment if your TSH is normal. Yes, so from thyroid point of view, they don't require treatment, but they definitely have an adverse effect on pregnancy, because their structure again is similar to protective antibodies or asymmetric antibodies. So if they are high, they can displace these asymmetric antibodies and have effect on pregnancy. So if we increase the concentration of asymmetric antibodies by doing immunomodulatory treatment, the effect of antithyroid antibodies can be displaced or can be overcome. And this any treatment that will increase these asymmetric antibodies will help in these cases. So once we know that these patients will be benefited by immunomodulatory treatment, because these tests have to be practical, we have to translate them into treatment. So what we do for these patients, or what immunological treatment we do, the treatment is called as immunomodulation. You know that. Now, immunomodulation is of two types, active and passive. Active immunomodulation means we give the treatment and it acts on patient's immune system, produces immunological response which protects the pregnancy, while the passive immunomodulation is use of medications that will help prevent the effect of excess immunological activity on the pregnancy directly. So for one example of active immunomodulation is, or rather the only example is lymphocyte immunization therapy, while passive immunomodulation, there are many medications. We'll see as we go ahead. So essentially the basic difference between the two is the active immunomodulation is more effective. It is long lasting. Why? Because it creates an environment like the natural protection of pregnancy. So it mimics natural protection of pregnancy. Therefore, it is more effective, and it is complemented by the passive immunomodulation. And of course, active immunomodulation is much safer than the passive immunomodulatory medications. So here is a list of different methods by which immunomodulation can be achieved, many of which we are using in our regular practice: the lymphocyte immunization therapy, IVIG, steroids, prednisolone, progesterone, anti-TNF alpha medications, intralipids, low molecular weight heparin, low dose aspirin, GCSF, growth hormone, L-arginine, endometrial scratch. So the list is endless. So what we should use and when we should use is the question. So I will be talking a little bit about the other immunomodulatory protocols or medications, and Dr. Mugdha will be speaking in detail about lymphocyte immunization therapy. Because after the lymphocyte immunization therapy, these patients are given this passive immunomodulation of those medications which I just suggested, I just shown, and they are given immediately after the Immulid procedure, then while during embryo transfer and during pregnancy. So corticosteroids, I think all of us are using, or many of us are using prednisolone or dexamethasone in these patients, and they are known to suppress excessive immune activation. They reduce inflammation and prevent embryo rejection. And many ART protocols, especially after transfer, this is used, prednisolone is used in the dose of 5 milligram 2 times a day from the day of transfer till confirmation of pregnancy. And many times they stop it, but in patients who have immunological problem, we may have to continue further. And up to 3 months of pregnancy in a higher dose of 20 to 30 milligram per day, which helps in, supports the effect of lymphocyte immunization therapy during pregnancy. Intravenous immunoglobulins. Now, certain centers do use this intravenous immunoglobulin. It modulates the NK cell activity, reduces autoimmunity. It is used for women with RIF and RPL, and it helps promote the immune tolerance. But this is not free from side effects. Those who have used it will vouch for it. There's increased incidence of thrombosis, hemolysis, renal dysfunction, and it was discontinued in UK because of the possibility of infection, the what is called as a mad cow disease. So that because of that, it was not in use for a long time in US, but it has in UK. It has mild effects like mild headache, fatigue, nausea, vomiting. So there are intramuscular immunoglobulins which are in use in our country and which are quite popular. This next is intralipid infusion. Now this also is very commonly used, and we do not use IVIG, but we recommend intralipid infusion because the effect is similar to IVIG, and it is much safer. You know, it contains essential fatty acids that regulate NK cell function and help shift the immune response to a non-anti-inflammatory or pregnancy supporting environment, and it's an alternative to IVIG. And there are studies which have shown that it has been associated with success rate of more than 52%, and those who conceive in patients with RPL, almost 91% have successfully continued the pregnancy. GCSF is also another one. It's a stimulant. So this enhances the endometrial receptivity by improving blood flow and immune regulation. It can be beneficial for women with thin endometrium or RIF. The important thing here is it requires proper monitoring with WBC count, because WBC count can go very high, and especially when it is combined with steroids, it can become very high, and sometimes many a times that is a for the doctor is a matter of concern, and we get many times calls related to that. But the permissible level of WBC count is quite high, and so we need not worry about it, but especially in combination with steroids. TNF alpha, when it is high, what should be done? That is the question that is regularly asked to us. The active immunomodulatory treatment helps in bringing down TNF alpha to normal. Abroad, they have been using, or they use anti-TNF alpha medications or TNF alpha blockers, and these are biosimilars. So they reduce pro-inflammatory cytokines and beneficial for women with autoimmune conditions, which are along with that. But in India, it is very risky because they tend to activate latent tuberculosis. So in India, usually they are not used, and even patients of Indian origin abroad, it is used with utmost care, or sometimes it is not used at all. Low dose aspirin and heparin, yes, all of us are using, even though there is no evidence of thrombophilia. Still, these factors are used because they prevent, anyway, they are blood thinners, they prevent clot formation, enhance uterine blood supply. But here, important thing to remember is aspirin blocks the thromboxane pathway and activates prostacyclin pathway, which promotes vasodilatation, which is important in maintaining the pregnancy. And low molecular weight heparin has significant immunomodulatory effect, and it enhances the adhesion of embryo. So naturally it is produced in the liver and it reaches the implantation site, and therefore patients with recurrent implantation failure, this becomes an immunomodulatory treatment, a passive immunomodulation after the active immunomodulation, and it improves the implantation success in ART. So all these different methods of immunomodulation, the active immunomodulation or passive immunomodulation, if we are using, what is the actual clinical practice guidelines? So if you say the ASHRAE, usually we rely on ASHRAE guidelines or ASRM guidelines or the Green Top guidelines. So you are of course aware that most of these guidelines, they do not recommend use of immunomodulation. So lymphocyte immunization therapy should not be used. Vaginal progesterone does not improve birth rate. Insufficient evidence for intralipid, heparin, aspirin should not be used. Glucocorticoid should not be used. Insufficient evidence for GCSF. Though the latest ASHRAE guidelines are now recommending IVIG for patients who have 4 or more unexplained recurrent miscarriages, and that is one condition where first time ESHRE has been recommending treatment related to reproductive immunology. So gradually, even the outlook is changing in the mainstream gynecological or fertility guidelines. But important thing here to remember, even the RCOG guidelines and ASRM guidelines also do not recommend. But if you go in detail of these guidelines, the studies on which this is based are still not recent. The ESHRE guidelines are based on studies up to 15 and ASRM in 14 and 2011. So there are a lot of newer studies which have come, which Dr. Mugdha will discuss, and which indicate that immunomodulation is very effective, and very soon we sure, because guidelines from American Society of Reproductive Immunology have also just come, and they have been recommending these immunomodulatory treatments with proof of studies, and definitely the scenario is going to change. So integrating immunomodulation in ART protocols or in patients who have recurrent pregnancy loss is very important. So you have to identify patients with immunological testing, customize these protocols using treatments like lymphocyte immunization therapy or Imulit, use passive immunomodulation after the active immunomodulation to enhance the effect of active immunomodulation, and monitor immune parameters throughout the treatment and adopt a multidisciplinary approach. It is very important to coordinate with the right reproductive immunologist to get the proper treatment for these patients with alloimmune problem. So from the treatment point of view, immunomodulation point of view, it plays a very critical role in ART and RPL success, and personalized approaches improve implantation and pregnancy outcome, and ongoing research is advancing immune-based therapies in reproductive medicine. So in future, they are going to play more and more important role related for patients who have reproductive failures. I think more to talk more on the active immunomodulation about which we have been working for more than 30 years. I will invite Dr. Mugdha to go ahead and talk in detail about the procedure of lymphocyte immunization therapy or Imulit, how it acts, and what are the supporting evidences, what are the controversies and success rates and safety. So I will invite Dr. Mugdha to go ahead with the talk further.
Sir, I'll just take 2 minutes.
Yes, yes.
Yeah. So I want to thank our chairpersons for the first and second session, because we continued, so I could not invite them. Sorry for that. So if you like our chairpersons for the second year session, sir, where Dr. Anuradha ma'am, Dr. Shalini Jain, Dr. Sunita Kanay, and Dr. Ruchi Ruprela. I invite all the chairpersons. I thank them, and if you want to like acknowledge, and Sushma ma'am also, if you want to
We are really thankful
Yeah.
to the chairpersons and for inviting us here. And I apologize. I think I was in a hurry to start. I think
No sir, no, actually webinar में ऐसा होता है, because yeah,
It's okay, sir. It's okay. It's very nice giving a flow to understand the things.
Yeah, we don't
Yeah.
want to break your flow. So, I invite chairpersons now to say few words regarding these two talks.
So, thank you, Dr. Mohan, for sharing your words of wisdom with all of us. Much gratitude, and it was pleasure to listen to you. And thank you for letting me chair the session, Anuradha and the IFS team. And we can go ahead. I think Dr. Mugdha can take the session, and then
because the most interesting part is coming now. I think I will invite
the lymphocyte.
So that will be an extensive session, and then we will have the case studies. And that will be still, I feel, because we want more time for that, and that so that's why we felt that just introducing to the topic and giving certain details, because we haven't covered everything about reproductive immunology, because questions will come from you. So that's why we want to keep some certain things uncovered so we can discuss them later.
Okay, it's a vast topic. Thank you, Dr. Mohan. Thank you so much.
Yeah, please welcome Mugdha ma'am. For that, I invite to chair the session Dr. Vinaya ma'am, Dr. Prakriti Verma, Dr. Shilpa Sakure, and Dr. Sudha Agrawal. Welcome again, ma'am. It was very enlightening. Both the talks were very enlightening, and now the main hero comes, the LIT.
Yeah.
Yeah.
Now, as Dr. Mohan said, we'll be discussing about active immunomodulation mainly. Now, what is Inulate? As I had mentioned in my talk in the first, this Inulate is our patented and branded process of which is based on lymphocyte immunization therapy. So, lymphocyte immunization therapy is not new. Billingham in 1953 had observed that skin grafts between fraternal twins were accepted, while grafts between non-twin siblings were not. Now, they put forward the hypothesis that some blood cells have to be exchanged through the twin placenta. In 1981, Taylor performed lymphocyte immunization therapy to treat patients who had for kidney transplant. Now, of these 4 patients had unexplained RPN. 3 of them delivered normal babies and 1 delivered a premature baby. But in 1985, it was Professor Alan Beer from USA who confirmed that inadequate maternal recognition of paternal alloantigens causes deficient tolerance to the pregnancy. Hence, immunization with paternal mononuclear cells might enhance maternal recognition of paternal alloantigens, helping patients suffering from recurrent spontaneous miscarriages. Now, how does lymphocyte immunization therapy work? It works by the development of blocking antibodies. Like Dr. Mohan told you, that antibodies in our body are always Y-shaped with 2 arms of the Y always symmetric. The blocking antibodies are asymmetric antibodies. And they do not activate the complement. They do not allow the immune rejection to attach to the pregnancy and activate complement and reject the pregnancy. So it was shown that LIT appears to enhance the development by intentional exposure of mother's immune system to living cells expressing paternal antigens. This was not only shown by Magni, but also our own Dr. Manoj Pandey from Lucknow, who now lives in Cincinnati, USA. T regulatory cell activation. There is always, after LIT, it has been shown that there is decrease in the Th17 T regulatory cell ratio and the Th1 Th2 cytokine ratio. The next is dendritic cells. Now, dendritic cells are something which are very important in the whole process of lymphocyte immunization therapy because dendritic cells in the skin interact with the antigen and present it to the immune system for the response. And this leads to further immunological changes which induce immune tolerance. Now, how does lymphocyte immunization therapy work? As I said, the dendritic cells, they act along with the allogenic lymphocytes. They combine, dendritic cells pick up the allogenic lymphocytes and they take them to the secondary lymphoid organs, which are lymph nodes and the spleen. There is activation of lymphocytes, proliferation of the lymphocytes, and then differentiation into Treg cells and B cells. Treg cells, as we had discussed earlier, are responsible for immune tolerance, and the B cells are the ones which are going to produce the blocking antibodies or the asymmetric antibodies. Now, what is lymphocyte immunization therapy or Inulate? The way we do it is a single sitting 3-hour procedure. It's a daycare procedure. There is no anesthesia involved. Blood is collected from the husband or the donor. The lymphocytes are separated and then the lymphocytes are injected. The precautions we do are prior immunological testing is a must to qualify a patient for whether the patient requires lymphocyte immunization therapy or no. Because if the patient has blocking antibodies more than 80%, then they do not require lymphocyte immunization therapy. A prior infection profile with the quantitative method, not the spot test, is a must. Blood groups of husband and wife are tested. The only reason we do the blood group is because if the wife is Rh negative, then we give anti-D injection. The patient is advised to plan the pregnancy 4 to 6 weeks after the therapy. The effect of the treatment lasts for 18 months. So within 18 to 24 months, they are supposed to plan the pregnancy. A booster dose, some centers do give a booster dose in the first trimester. We have never given. And LIT can also be given in pregnancy. We have done 20 patients till now who have presented to us with pregnancy. And the test had showed, with recurrent pregnancy loss, the test showed that these patients will require the therapy, and 18 of them have succeeded to a full-term pregnancy and an uncomplicated pregnancy. Now, what are the side effects? There could be minor local allergic reaction, a feeling malaise, but there is no serious side effect like anaphylaxis, no graft versus host disease if done in the proper way by qualified people. The largest study came by Kling in 2005, where he studied over 4,500 cases of the mothers and the babies born after LIT, and they did not find a single case of autoimmune disease or graft versus host disease. Again, that is if done properly by qualified individuals. Now, Dr. Mohan already told you that Amulet has to be combined with passive individualized immunomodulatory protocol, which are individualized to every patient. All the patients are not given these treatments. We have enumerated only those, and Dr. Mohan explained to you what are the medicines, what are the side effects, and how do we use them. So we use the medicines which are safe for the patient and the baby also who is going to be born, and also we have to individualize it. So we are always in touch with the patient on the day of embryo transfer or if the patient conceives naturally. And then based on their reports, we send a protocol of medicines to their doctor. So the doctor administers it in their city, and we are always in touch with their doctor to know what is the beta HCG, the progesterone, and all other things we discuss with their referring doctor. Now, if lymphocyte immunization therapy is so good with a 75 to 80% success rate shown worldwide, why was lymphocyte immunization therapy, why did it lose its charm after 1999? It was widely used worldwide till 1999. Now, this happened because of the REMIS study. This REMIS study, it showed that immunization with paternal mononuclear cells did not improve pregnancy outcome in women with recurrent miscarriage. And they showed that 65% of control patients became pregnant and only 35% of those who took LIT became pregnant. And because of the lack of benefit, it recommended against LIT as a treatment for unexplained miscarriages. And it in fact showed that there was a higher miscarriage rate and a greater gestational age at the time of miscarriage in the immunized group. Now, this study came up in the Lancet. There were a lot of flaws in the REMIS study. It is the only study published till date that observed a negative effect of LIT on the rate of live birth rates. If you have heard my previous this, it is the use of live cells. So the prepared concentration of paternal lymphocytes was done using blood that had been stored for several hours at a temperature between 1 to 6 degrees. And this is something which the lymphocytes lose their antigen on it when the blood is stored. And this blood was used for this study. It was discontinued even before it reached the initial expected number of participants. It did not exclude and treat patients with autoimmune disorders. Like Dr. Mohan said, that could be coexisting. So we need to treat both together. And the most important was the lack of the post-immunization individualized protocol, which was very important after the couple attempted the new pregnancy. And the lymphocyte concentration never came up and was never published. Now, unfortunately, what happened? The Cochrane review, which came in 2003, was heavily based on this REMIS study. And so it recommended again, saying paternal cell immunization, third-party donor leukocytes, trophoblast membranes, intravenous immunoglobulins also provide no significant beneficial effect over placebo in improving the live birth rate. So according to this Cochrane meta-analysis, the odds ratio is only 1.22. That the chance of having a successful pregnancy after LIT is only 1.22 times more than not doing LIT. Now, there was a lot of hue and cry against this study. Now, if you can see the previous one, it had a 34.3% weightage on the Ober study or the REMIS study. Now, the next Cochrane meta-analysis, which came again till this was till 2004, showed an odds ratio of 1.63. This was only the studies till 2004. Still, it showed an increased value. 1.5 times more chance of a successful pregnancy. Now, Liu in 2016 added all the other papers and analyzed the whole study without the Ober study. And he found that the odds ratio was 4.02. That is, the chance of a successful pregnancy is 4 times higher after giving lymphocyte immunization therapy than not giving it. Cavalcante later in 2017 included the Ober and Stray-Pedersen studies. And still, he found that the odds ratio was 3.13. That means the chance of having a successful pregnancy was 3.13 times more. Now, there was again a meta-analysis of LIT for the treatment of repeated miscarriages in 2021, which again showed an odds ratio of 3.22. Now, all these studies, all the LIT studies and the evidence, we have analyzed and published in our book, which was published by Springer 2 years back, Springer Nature. We are the only 2 authors of the book, and it's the first of its kind book on lymphocyte immunization therapy in the whole world. So now, what is the recent meta-analysis? Now, the recent meta-analysis, if you see from 2014 to 2021, it showed a consistently increase in the odds ratio of that is the chance of having a successful pregnancy from 1.23. It actually went up to 3.22. So what was the conclusion from the Liu and the Cavalcante meta-analysis? That the LIT is a safe treatment. It stated that LIT is valid treatment for couples with repeated miscarriages when performed with lymphocytes from fresh, non-stored blood. It is beneficial when given before and during pregnancy. The best results are seen when LIT is done with adequate number of lymphocytes, and most effective when it is injected in the skin. And LIT is beneficial in well-selected couples. You cannot pick up every patient and do the procedure on them. Now, what was our experience? Our center in Mumbai was we were doing it elsewhere, started in 2013. It was inaugurated by Professor Christensen from Denmark, who has done a lot of work on LIT and subsequent passive immunomodulation. Now, we have till now treated 4,000 plus patients from India and abroad. We have a strong collaboration with IVF specialists and gynecologists. We don't do IVF. We don't do our regular gynac practice also. And we have found a very high safety profile when we use a standardized protocol, and now there's increasing acceptance. We have published this in the American Journal in 2017, where we had got a success rate that is of 82% success rate in patients with repeated miscarriages. In 2018, we presented our paper of recurrent implantation failure we found a 67.7% live birth rate and a 73.8% clinical pregnancy rate. Now, in 2023, we submitted a paper of 144 women who were treated with Immulit, and we observed that of the 121 women in whom the follow-up was available, 21 did not conceive, but 88 had live births, and 12 experienced miscarriage, resulting in a success rate of 72.7%. As I said, this is our book which was published by Springer in 2 years back, and it is the first of its book on lymphocyte immunization therapy, reproductive failures, New Horizons, and only Dr. Mohan and me are the only authors. It's not an edited book. So here we come to the story of Shauli and Penny. She came here, we investigated her as per the investigation which Sir had suggested, shared with you all. And she underwent Immulit at our center. And today Shauli has a baby boy. So this is what immunomodulation can become the missing link if treated properly. Now, why our unique approach is we don't use a personalized plan. There's no one size fits all. There is seamless collaboration. We focus on immune balance. You all handle the fertility and obstetrics. And we base our advanced protocol based on global research and experience. And we, of course, do a lot of patient education, and we empower the couples with all the knowledge possible which is there. So how we collaborate with the IVF specialists and the gynecologists, we interact with them once the reports are ready. We give timely updates after treatment and reintegrate them into IVF and obstetric care. And there's always ongoing support and co-management, and there is never a competition because we don't do IVF, we don't even do our regular obstetrics or gynec practice. So as Sir had suggested, I had already discussed, when do we refer 2 or more miscarriages, 2 or more IVF failures, or older patient with a low AMH after 1 failure, unexplained infertility beyond 2 years, biochemical pregnancies without known causes. Now here is very important, we like to tell everyone is what we don't do. We do not perform IVF or IUI. We do not offer any obstetric care. But we complement your treatment to improve the outcomes, and we return your patients back to you for care and follow-up. We have designed a simple 5-step process. We ask you to share the patient's number with us. We book an online consultation call. They get investigations done in their city. Then, as I said, we are now 7 centers. They can come for a single 3-hour treatment to one of their nearby centers. Then once they go back to their doctor, we tell them to inform us the day of embryo transfer if they conceive. We give a list of post-immulit individualized protocol to their doctor. And of course, the 5th step is enjoy parenthood. So unexplained repeated pregnancy reproductive failure is known to have an alloimmune basis. Proper selection of the subgroup of couples with immunological tests for LIT is important for successful outcome of subsequent IVF procedure and pregnancy. And use of immunomodulatory medicine during an embryo transfer and subsequent pregnancy play a crucial role in improving the take-home baby rate, preventing miscarriages. Thus, immunomodulation is most likely to be the missing link in the treatment of unexplained RPL and RI. I would like to end with the words of Sir Peter Bedavar again. The purpose of science is to change belief. And if you believe that infertility, implantation failures, recurrent miscarriages, actually this could not fit in the slide, but he has extended to preterm delivery, PIH, are God's will, which is not treatable scientifically, you will never try to find an effective treatment. Thank you. So now we are open for questions. We let all discuss our cases and we can go through complex cases.
Thank you, ma'am.
Bolo.
Go ahead. Thank you, ma'am. Thank you. It was very crisp and very short, very sweet. But I have so many doubts, ma'am. What are the immunological tests should we go for before LIT?
Yeah, so I think sir should answer this question. Okay, so the test which we do, frankly, is which sir showed in the slide is lymphocyte cross match, peripheral blood natural killer cells. We do the TNF alpha, antithyroid antibodies, mainly anti-TPO and anti-thyroglobulin. We do the CBC of the husband and wife. We do the serum homocysteine. We do a lipid profile and
Endometrial biopsy.
yeah, if you're doing an endometrial biopsy, then otherwise, yeah, and a HbA1c and FBS of both the husband and the wife. Because if an HbA1c is above 5.7, then the chance of an immunological problem interfering the rejection, because the body will want to protect the mother's body, are very high. If the lipid profile is high, let me tell you, lipids, when the lipid profile goes high, there is something called M2 macrophages which are responsible for innate immunity. They are present in the uterus. We call them the first line of defense. And when the M2 lipid profile goes up, M2 macrophages go down, and then the signaling of the embryo gets affected. So macrophages are equally important in the innate immunity, and treatment with for 2 months with Rozuvas. After Inulid, we ask them to be treated with statins for 2 months before you plan the treatment. So this is a very, very important part of these other tests, and the infection profile and the blood group.
Infection profile में what are the infection profile, ma'am?
Infection profile, we do the VDRL, hepatitis B, HIV 1 and 2, and HCV by the quantitative method, that is ELISA, CMI, or CLI techniques.
Okay. Ma'am, in the slide, it was there like tumor necrosis factor, if it is more than 4 to 12, like 12 is the cutoff. So
Yeah.
when you take it as how much is high, like more than 12, more than 15, more than 20,
More
how
than any value more than 12.
is
Because
high?
high, it just indicates that somewhere immunological imbalance has happened. Otherwise,
There.
the body will never keep it more than that, because it is detrimental to the own body. So it will,
Own
when
body.
it increases, it shows an immunological imbalance towards the inflammatory type.
Yes, ma'am. And anti-TPO antibody, like, is there any value for that, ma'am? Like,
Yeah, so we don't give the value because each lab gives its own value.
yeah.
Metropolis has one, Agilus has one, Lalpat lab has one. So we see what the lab is the higher limit for that value, for that lab, and then we decide that. Because some labs, even at 6, it is a higher value for them. I think
60.
this is less than 4 or
60.
something. Yeah. For some patients, it is even 60 because it depends on the
60.
kit. Yeah, some say
It's
60,
good.
some say even below 4 is also high. So above 4 is also high. So we see the lab value, and we do all the tests from standardized labs like Metropolis, Agilus, Lalpat lab, Lupin does it. Yeah. So
Yes, yes.
Metropolis is there with us for 30 years, so they know what we want. So they do it fastest.
Ma'am, if TSH is not high,
Yeah.
but anti-TPO antibody is getting positive like high, then it will be cured by other immunological treatment, or we have to go for thyroid treatment for this patient, for such type of
Like
patients.
in third slide, he showed that 80% of the women who have raised antithyroid antibodies are clinically euthyroid.
Thyroid. Yes.
Yeah, yeah.
And just treating them with the medication is not going to help. Antithyroid antibodies will never reduce in the body. But what happens is that when you do Inulid treatment, you're increasing the level of the blocking antibodies.
Yeah, yeah.
So the blocking antibodies then they competitively inhibit with the antithyroid antibodies. So antithyroid antibodies will never reduce in the body, will never find a low value. But because we are increasing the blocking antibodies, antithyroid antibodies cannot come and attach to the uterus.
Yes, ma'am. One more, ma'am, I have doubt. If a patient is having APLA, like it is positive, beta 2 microglobulin or LA factors are positive, still, if they are not cured, like they're not getting pregnancy with low molecular weight heparin, aspirin, and yet, then can we give them the lead therapy and immunoglobulins?
Have to investigate them because these can coexist.
Yeah, that's right. Huh.
These factors can coexist, so you have to give them. Immunity is going to be really helpful. First, investigate whether they have this factor or no additionally.
For
And
them, any special test, any extra, like any specific
no,
test?
nothing. These only tests which we do.
These only tests.
Alloimmune rejection, that is autoimmune. I mean,
Yeah. Autoimmune.
So that has to be treated, and we always say all coexisting factors also have to be treated. So just doing this therapy is not the answer. We have to work together. So everything has to be done together.
Okay.
Hello, ma'am. I wanted to ask, how do you assess for blocking antibody? Is it by CDC cross match we are
Yeah.
looking at?
Yes,
By with husband as a donor.
husband as a donor.
Okay, so that's the only test from which we are assessing the blocking antibody.
Yeah. It is a gold standard test. Means if it is negative, that means definitely an immunological problem is there.
Yeah,
If the patient is conceiving naturally and the patient is having recurrent pregnancy losses and patient is showing that patient is APLA positive and ANA positive, and if you want to give intralipids, but patient is not looking for any type of ovulation induction or any IVF procedure because she is conceiving naturally. So in that case, can we give intralipids at around the time of ovulation or if the patient conceives in such cases?
Yeah, madam, actually, this is one thing which patients have a misconception we have seen, that they are conceiving naturally. Doesn't mean that even we all know that there could be a genetic problem.
Yes.
There could be, so they can't accept that because you're conceiving naturally, don't have other problems. So we have to explain to them that even if you're conceiving naturally, we often get this. Even if we are conceiving naturally, there are many times where the problem could be the embryo.
Yes, ma'am. I have a patient of 8 implantation, 8 missed abortions, but she conceived after blastocyst transfer. 8 natural pregnancies and missed abortions, and she conceived after blastocyst transfer.
Yeah, so it is very important. And then if you do the other tests for alloimmune, but you have to also consider that. So we always, when we counsel the patient, also we ask them, has a microarray been done? Has your karyotype been done? Because sometimes they've done nothing. And they just say, no, I'm conceiving. I don't want to do anything more. I'm just conceiving.
Yes, the same
Yeah.
thing they used to say.
So-
There is not problem with my conception. There is problem of abortion. So I don't want to go for test or any other treatment.
Yeah. Because even the husband's karyotype, many times the husbands don't accept, and we all know 50% of the times it could be the male factor. So doing that is also equally important, which we need to counsel the patient. Like you're saying clearly, she conceived with blastocyst transfer. There is some problem with the embryo.
Yes,
So
ma'am.
that is extremely important. And see, intralipid is better to give it if the tests are showing you do immunite and then give it. Because intralipid also has its own side effects. It can have drug allergies, it can have other things. So rather than just giving anything, then better to do the test, see if the patient has it, do immunite and then give it if she requires. So because we've had
I have one question, madam.
Yeah.
If we are treating this immunotherapy to the female, what test would you like to do on the partner, like the husband, before giving?
Husband also we do a CBC, we do a HbA1c, the fasting sugar, we do a lipid profile and a serum homocysteine.
Okay.
Because according to the recent studies, even an elevated lipid profile in the partner is going to cause affect acrosome reaction. The sperm may look normal, but that can cause their elevated HbA1c, even their homocysteine may be high, which can affect the actual quality, which is still not seen. So there are papers which are coming up showing that when you control it, like giving statins and controlling the HbA1c, it is definitely helping in conception.
So we want both the partners to be tested before giving immunotherapy. That's what we want.
Yeah.
Right?
Because
Thank you.
Ma'am, if we are giving like statins to the mother, like female partner, after embryo transfer, we have to stop it because we cannot give
Yeah,
during
you
first
have to give it
trimester.
before. Because, see, we have to give it before, and you have to stop it
Hmm.
when you can stop it even when you're starting the induction.
Okay.
Yeah, so 2 months, and only what is recommended is rosuvastatin,
Rosuvastatin.
hydrophilic statin. Now, there are two types of hydrophilic statins, rosuvastatin and pravastatin. Now, pravastatin is not available in India, but it is available abroad and they give it even during pregnancy. Because, of course, they are patients, we know how huge they are, they have other lifestyle disorders. Our patients are not that huge. So, I don't think any patient, unless she's 110 plus kilos and then requires pravastatin. But rosuvastatin 2 months before is absolutely fine. But stop it or if the patient conceives, stop it immediately. Or if the patient has an embryo transfer or a regular plan, you can stop it.
Yeah, one more
So
question, madam. This intralipid and immunoglobulin that every 3 weeks that we get. Suppose if it's an IVF patient, embryo transfer, when to start that therapy? This
We recommend
immunoglobulin
embryo transfer.
just before the transfer?
Yeah, on the day also you can give.
Okay. And intralipids also on the day?
Yeah, immunoglobulins we give intramuscular. We don't give IVIG.
Yeah, sure.
We only use intralipid because it is safer. So we recommend it from the day of embryo transfer. And we recommend intramuscular immunoglobulins like Bharglob or Intaglob
Yes.
the same day and then every 15 days. Intralipids have to be given every 15 days actually.
And Bharglob is 3 weeks, I think. Every
Actually,
3 weeks.
we give it every 15 days because it's convenient for the patient to take it every
both at the same time.
lipid, they can take Bharglob with it.
ma'am, if you are going for lead therapy, like you are telling once you are giving. And after pregnancy positive, like 6 weeks, 7, we should repeat it?
We have done 4,000 plus cases. We have never repeated in a single patient. In pregnancy, we give those patients who have come pregnant with previous miscarriages. If the tests show, in them we do therapy in pregnancy, but they have never undergone before. Like one patient had come to us from about 300 kilometers from interior Maharashtra. She had a history of 3 early onset PIH, IUFD, and 1 miscarriage. So in the 4th time she conceived, the doctor did all the tests. And then she was 2 months pregnant when she came to us. We did the therapy. We started her with all the passive immunomodulation immediately. She went back to Parbhani and there her doctor gave the rest of the medication. She had a completely uneventful pregnancy till 37 weeks and a cesarean was done only because of the high risk nature of the pregnancy. Otherwise, completely, and we did 20 patients till now in pregnancy, of which 18 did very well, 2 didn't succeed.
Ma'am, is there any time interval like first lead therapy and embryo transfer? Is there any time interval?
That it depends on the patient's reports. So some patients, we say 4 to 6 weeks. But some patients whose TNF alpha is very high, we ask them to wait for 8 weeks.
Between lead therapy and embryo transfer.
And may I ask a question? Do I have experience with HCQ? Any experience? Hydroxychloroquine in recurrent implantation failure?
Yeah, it is an immunomodulatory medication. So it is very useful.
Can I add? Yeah, we regularly recommend HCQS means as an immunomodulator. And one important role it plays, what we have seen is we don't check all autoimmune factors. Okay, like all say anti-phospholipid antibodies, phosphatidylиnositol, phosphatidylserine, we don't check. So it helps to take care of these undiagnosed autoimmune conditions, and it's a safe molecule, can be used throughout pregnancy. So usually we recommend it post LIT and continue it, ask the patient to continue throughout the pregnancy. So we have been using it very regularly and it has been found to be useful, though it's part of total prescription. So we haven't used it in isolation, But yes, it is an important prescription. I will recommend you to.
Sir, in what doses do you use it?
We use it at 400 milligram HS or once a day. And only important thing to remember is it has effect on eyes. Okay, so any visual symptoms is something which should be taken seriously. If possible, before starting, an ophthalmologist's opinion can be taken, and so that way it becomes very safe. And some patients have issue about tolerating HCQS, but most of the times it can be continued. Our rheumatologist friends vouch for it. Their patients, even when they get pregnant, they continue. So it's a very safe medicine and useful.
It can be
Yeah, we
continued
too have
throughout the
very good
pregnancy.
experience with
Yes,
these
yes,
patients.
Till end.
Yeah, till it.
So
Do you
I
can
had a
monitor
patient. Sorry.
LFT also when you provide these molecule to the patient?
Regularly, not.
Not.
So
Can I
what?
ask? Thank you,
Yes.
sir. Thank you, sir, for your valuable input.
Sir, can I joined. Good evening, sir. I joined late. Sorry.
Go ahead, ma'am. Go ahead.
We were talking about. I think we were talking about hydrochloric HCQ. I think.
Yes, yes.
So, sir, I listened that it was 400 mg. You told.
Yes.
So, anytime you in any of the case you gone through any side effect with it, like in your
Only
practice.
in so many years, there was only one patient who had complained of visual disturbances, some dark spots, and we immediately stopped, and it just
Recovered.
she
It
recovered
recovered.
completely.
And
Yes.
there are some patients who already the ophthalmologist has given not to use it. We don't use it only.
Any ophthalmic
Any
complaints?
ophthalmic complaint they have before and they have been recommended not to use particular medicines, then we don't recommend it at all.
Okay.
So, can I ask a question?
Yes.
So
Yes.
I have a patient who had 2 recurrent miscarriage in the early pregnancy. Genetic cause and all the basic causes like anatomical and everything was ruled out. So we have done her HLA CDC cross match. It was normal, and TNF alpha we have found to be 44. It was very much raised, and she had anti-thyroid antibody positive. So what do you recommend for this patient?
She will be very highly benefited with this Imulate treatment.
Okay, you mean to say active
Active
LIT, even if the CDC cross match shows she has the blocking antibody, then also we should
No,
do.
it is negative. No, CDC cross match is negative.
That is normal. It means she
No,
has the
negative means
it is
she doesn't
positive.
have.
I mean to say positive. She has
How
the
much
blocking.
positive? Like more than 80%?
I'm not sure about it.
Just
But
check the
if we
report because
consider this as a positive, then also we have to go about
then
it. Like
they don't
tumor
require.
necrosis factor alpha is raised and anti-thyroid antibody is raised.
See, it will depend on how much of the CDC cross match is positive. Because if it's more than 80%, that means they don't require. If it is
Okay.
lesser than that, they do require.
Okay. Okay. And about tumor necrosis factor alpha, something has to be done because it is 44, so it is very
So once
raised.
you do the therapy, it starts coming down. You don't need anything to know
Anything extra.
I just wanted to know the cost of LI, this Imulate. What is the
See,
cost of
the way we do it, it's a single sitting, one-time procedure. The total fees for the Imulate procedure is 95,000. It is a one-time procedure, and then the follow-up medications and all are part of it. We are in touch with the doctor and the patient till the delivery. So this is a one-time fees, and we have online consultation. There are different.
And this includes the investigations and all, or they are separate?
No, the investigations are done separately by the patient.
Thank you for that, because sometimes I may need your help for my IVF patients. So I just want a rough idea.
Yeah, so the investigation may cost around 17,000-18,000, which includes all infection profile and everything.
Everything, lipid profile and homocysteine. And
How much time it takes to get the reports?
7 to 10 days.
Okay.
We can do it locally here, you said, right? The reports can be done here.
Metropolis is there, Agilus, Lalpath lab. So we generally prefer a standard lab because better to have standardized reports from these reports here.
Ma'am, what will be the level of homocysteine you take, ma'am? serum homocysteine level.
Yeah, now again, I'll tell you this always depends from lab to lab. Okay. So some labs say above 12 is high. Now, if you see the Agilis report, they say if it is 12, 8 to 12 on a patient who is taking folic acid, it is considered to be high. But mostly it is above 12 is usually high.
Then
Whatever
for
the
that, then you are giving activated folic acid
yeah,
till
actually, yeah,
till end.
Yeah.
Till end. Okay.
I have, ma'am, one patient who is a case of recurrent pregnancy loss. She had 3 missed abortions, 1 IUD, and she used to conceive naturally. But even with IVF, she had missed abortion and IUD at 20 weeks. And she is a known case of SLE. She is RA factor positive, APLA positive, and I have given everything to her. I have given low molecular weight heparin, azathioprine. She was already taking because she is SLE positive and she
SLE
has
positive.
polyarthritis. So she was already taking azathioprine, HCQS, low encosprin since I think 5-6 years. And low molecular weight heparin I have given 60. And with 60, she had bleeding. Then I reduced it to 40. But at 11 weeks, she had missed abortion.
You must
And
rule out.
in
this-
previous
you
pregnancy
must-
also, she was conceived with treatment. And at 20 weeks, when I sent her for anomaly scan, it was noticed as IUD. And even with IVF, and she is taking every drug which has to be taken in the case of SLE because she is already consulting with a rheumatologist at Delhi. So,
But I think
what can I do for such patients, ma'am? I
you
have
must
given
rule out
intralipids and
alloimmune.
everything.
You must rule out alloimmune cause.
I will
Can I
send her to
just
you, ma'am,
I
because she
have
is very close to me, and I will send her
Sure,
to-
madam.
for at least consultation.
Yeah,
Whether she is satisfied or not, I don't know, but I will send her.
sure, ma'am. Can you all excuse me? I have a patient who has come out to see. So, sir will be there to continue.
Yes, sure, ma'am. Sure,
Fine,
ma'am.
back in
Okay.
some other-
Thank you so much.
Thank-
Ma'am. Thank you.
Thank you,
Thank
ma'am.
you,
Thank you.
Thank you, madam.
She'll just come.
So I request all the other panelists if they have any questions. Dr.
Yeah, you can
Um,
put questions also.
Can I share my case if not yet discussed?
Yeah, please.
Sir, I had a patient. She was having history of menorrhagia like 8-9 years back, and at that time her although this is not an autoimmune disorder kind of patient, it was clear. So she had menorrhagia. Her sonography was showing hydrosalpinx and all. But she went to 3-4 gynecologists, but nobody advised her for like a diagnosis for endometrial biopsy or something. When she came to me with at that time she had amenorrhea of 1 year, and when I went for hysteroscopy, there was pus came out from the uterus. So and it was when we sent for CB naught, it was positive. So once we prepared, we did all the anti-tubercular work and the embryo transfer, but endometrium failed to grow. And with all these therapies, like we did sub-endometrial PRP installations also, the injections and installations also, all the things. But endometrium not crossed by 5 mm. So what we can do in such case?
Yeah, so the cause is obvious, I think, doctor. She had endometrial
Bad
tuberculosis,
tubercular, very,
damage
very
to
old.
basal line of level of layer of endometrium. So in these patients are really challenging. Means if whatever hormonal supplements you give, the linings don't grow. Even PRP or as you mentioned, it did not grow. So the immunological treatment, what we do, yeah, they are not specifically for patients who have thin endometrium. Okay, but there are certain patients with unexplained thin endometrium. There is no history of COX, nothing, but somehow endometrium doesn't grow. Sometimes they may have anti-estrogen antibodies, although those type of patients, we have a few of such patients who were after LIT, their endometrium started growing well. But in LIT is not the treatment for thin endometrium, and we have to find out the cause why it is doing. Otherwise, they are difficult to treat. Immunomodulation also may not be helpful for these patients, because here the cause is, I think, quite
Yeah.
clear.
Yes, it's
So
clear.
I think that's very difficult. I think all our other doctors here also will agree with me that in endometrium is always a challenge. And
Absolutely right, sir. Absolutely right. They have already destroyed the endometrium, the implantation capacity of the endometrium.
right.
Yeah.
So stem cells and all, they say we don't have any
Uh,
experience, but those results are also not very encouraging. So that is one definitely a challenge.
Yes.
Yes.
Hello.
Recently, there's a molecule called thymosin alpha, which is being aggressively marketed by 2, 3 companies. Like we can use in recurrent implantation failure cases before IVF during endometrial preparation. So, what is your view considering its cost and its relevance according to you?
So see, thymosin alpha, it's a thymus extract, okay? And its basic use is in cancer treatment, that. Because it helps in increasing the leukocytes, okay? It increases leukocytes, including neutrophils. Okay, we don't want that. What we want is increasing the lymphocytes, okay, and protective lymphocytes. So the physiologically that doesn't match actually. So there are studies which they tell us that it increases the Th1, the Th2 response decreases Th1. We have never used it. Maybe we have never felt the need, but the scientifically that is not the thing. Internationally also, I don't think it is being used, though it is, yes, marketed something very aggressively. And so we don't have experience, but some of our friends who have used, means we get patients who have taken this for 2 months, 3 months, whatever, I think 50,000 per month or whatever. So, and they were not successful because I feel it's not physiological, it's unphysiological from its action. So it increases the overall leukocyte count. So therefore, I think we haven't used it and been required to use it. If any of you have experience and used it, you can always share. It's good for everyone. But
Sir,
overall,
what is your take on IV immunoglobulins?
yeah, immunoglobulins, they are important. As I mentioned briefly in my talk, that they will decrease the inflammatory activity. But what we found was the intralipid has also the same role and same action. So why use IVIG when we have a cheaper and safer option than IVIG? So therefore, we haven't been using, or we don't recommend using IVIG for that purpose, but we do recommend intralipids regularly. IVIG, it is, as I said, the ISHRAE is the only treatment that they have recommended for 4 or more
Yes.
miscarriages. But we feel intralipid plays a good role. So as an adjunct after the active immunomodulation.
Thank you, sir.
How frequently you give intralipid?
It is given every 15 days. So we, in patients who are RPL, once patient conceives, immediately it is given when it is pregnancy is confirmed every 15 days till 20 weeks of pregnancy, 20 or sometimes up to 24 weeks of pregnancy.
So when I read through its content, there was written egg yolk or something in
Yes.
IVIG, yeah, this intralipid. So I was little afraid with giving this thing.
Yes, there
So
is
are
potential risk for allergic reactions. That is there. So therefore, first time when you are giving, it has to be very careful, like we do for blood. 8 to 10 drops for 15 minutes. See for any allergic reactions. If not, only then increase. Give over 1.5 to 2 hours. So even if it's 2
Sir, are you giving 100 ml or 250, 200 ml?
complete.
250
with
complete.
250 ml. Okay, sir. Every 15 days, 250 ml.
Right.
And then
Okay.
if you have started and you have given the intralipids for 20 weeks, then you abruptly stop at 22 weeks,
Stop. Then you stop.
or we need to taper it.
No, so why up to 20 weeks also is a question many times asked. Because what happens is around 16 to 18 weeks, there is second wave of placentation. So that if that doesn't happen properly, the placenta becomes dysfunctional, and that leads to early onset preeclampsia. And what Madam was telling, that which is typically those patients who escape the alloimmune problem in the first trimester, it may present at 16 to 18 weeks, and they end up with severe preeclampsia, fulminantly BP high, you can't control oligohydramnios, IUGR, IUFD at 21, 22 weeks. So those type of patients, so therefore to cover that period, we recommend even dufastone, dydrogesterone, we recommend till 20 to 24 weeks. You must be giving that because it also has immunomodulatory role. So therefore, that period is very important, up to 24 weeks, because immunological factors can come that late also.
Sir, what is the doses of steroid you are giving to the patient? Because I have received one patient from Dubai and she is taking 16 milligram twice in a day. She came to me after the embryo transfer in Dubai and she was receiving 16 mg BD.
Methylprednisolone, you meant to say. You are saying methylprednisolone, right? Because
Vicilone, methylprednisolone.
Vicilone, 30 milligrams, that is 10 milligrams 3 times. We give 30 milligrams. 10 milligrams 3 times a day. If the 20 to 30, 20 is usually recommended dose, but what we have found, 30 is still better and it is safe. It doesn't have complications. Of course, you have to monitor sugar, blood pressure as we do for, but it's a short-term steroid. And then you taper after 12 weeks, taper over next 2 weeks, make it 10 milligram 2 times, 5 milligram 2 times, and then stop. So,
because there is sugar level increases after the steroid. So
yes, so therefore that has to be checked.
Sugar and BP both rises.
Sir, there is one patient.
Sir, till how long you give? You continue.
आप पूछ लो मैम.
Sir, just one last question: that how long you continue with the steroids?
I told you just 12 weeks, and then you taper over next 2 weeks. So
by 14 week you finish.
yes.
Okay, sir. Okay, sir. Thank you, sir.
Sometimes if the patient already has, say, borderline or diabetic or gestational diabetes, something like that, dosage can be reduced, but it has to be titrated properly with sugar level and diabetic medications. But 11 weeks also you can then reduce and stop after 2 weeks.
A word about tacrolimus. Have you used in which subset of patients?
Yeah, so we as a first line we don't use, but those who don't see, nothing is 100%. Even all this immunomodulation or even immediate treatment after that, those patients who don't succeed, we recommend them to the doctors who have referred us. And tacrolimus is a good medication, but it has certain side effects. It tends to increase the blood sugar and it is renal toxicity. So we have to do RFTs, renal function test, sugar, and then start at a lower dose, because recommended dose is just 1 milligram, which is quite low. And then it can be increased to 2 milligram per day, and sometimes up to 12 weeks also it can be continued. But it is, there are studies now which have shown that it is effective, but it has to be used carefully and with proper monitoring. Yes, not all patients, but certain patients.
So in second line, we can use this.
That's what we feel those who don't succeed.
Not responding.
Sir, you told about CD57.
Right.
So in a patient of recurrent pregnancy loss, RPL, what else we should plan for those patients in a metro sample?
Plan means the investigation wise?
I mean, yes, investigation wise for endometrial biopsy in the specimen.
OH workup first, right? So that all you will anyway do from genetic.
Yeah, we will do that, everything.
Okay. Then to rule out immunological factor, that is the alloimmune factor, as we mentioned in the talk, we do tests to find out about the protective blocking antibodies, the NK cell imbalance, and TNF alpha levels. So they help to know or to diagnose that this patient has an alloimmune problem, because these are, see, there is a big list of investigations. If you see, the different labs promote different investigations. That also I was expecting some question on that, different investigations, extensive investigations, but as actionable investigations, we use these specific and antithyroid antibodies, because we can specifically give something related to that. If the protective antibodies are not there, we can give LIT. If the NK cells are, the imbalance of TNF alpha is high, accordingly we can use immunomodulation. So these tests are useful in planning the treatment. So therefore these are and simple tests, easily available and easy to interpret, rather than complicated cases, because there can be a big list of investigations and which are sometimes recommended or certain labs tell us to do. So, but these 3 tests help us to, or 3 or 5 tests help us to select couples for immunomodulatory medications.
Okay,
Good
if
idea.
she is coming to be CD57 positive, then she has to go for LIT will work for her.
Yeah, LIT followed by other immunomodulatory medications
Will do.
will be beneficial, but still we do a cross match just to confirm that definitely the protective antibodies are already positive, strongly positive, then it will not add to this. So the problem may be additionally some medications she will require, but not the LIT procedure. So there's so many patients, sometimes there was a patient who had 8 miscarriages, but she was cross match positive. So it's not going to be beneficial. So we have explained to them, and then she was put on certain medications. That's it.
Sir, previously we are discussing about tacrolimus. So do you have to use blood level? How frequently we have to do, if at all, for tacrolimus?
No, so actually there are different ways. So we don't actually use it in our patients. In the sense we recommend that, but there is one way is starting it beforehand and do actual tacrolimus levels and what dose is suitable for that, and then that dose is started in the next cycle before especially those who are undergoing IVF. But otherwise for RPL patients, then it should be, of course, once the patient conceives, but I am not sure about the levels because we don't regularly use it.
Usually, what is your dose, sir? When you use like 1 milligram, 20?
That's what I said, 1 milligram. And if it is the patient is undergoing IVF, then 2 days before transfer, we start and we recommend to start. And once patient conceives, make it 2 milligram per day and to continue.
The NK cell you have told, so this has to be estimated. This is endometrial NK cell, uterine NK cell.
Right.
So we have to take the biopsy on day 21.
So if biopsy is being done or means hysteroscopy is being done, then that can be sent for immunohistochemistry for CD57. Related to blood NK cells, so there is still a little controversy. So there are different types of cell types, CD3, CD4, CD16, 56. So what we have found in our studies, and that's what our unique observation, so which we use for our patients, that the overall CD3 count, if that is high, that indicates more inflammatory activity, while CD16 plus 56, which is the conventional NK cells, what they are called. So usually it is said that if they are high, then that is not good. What we have found is if they are even low, below the normal level also, these patients are usually, more commonly they are associated with pregnancy loss, and these patients are benefited by immunomodulation also. So a CD16, 56 low levels correspond with the, because there is a theory that the blood NK cells, they go into the endometrium. These two are different type of NK cells, but they change their character once they go into the endometrium. So therefore, if the blood CD56, CD16 plus 56 are low, usually endometrial are high, and so that is the correlation. So you need not have an endometrial biopsy, but blood tests can help you to select couples who will be benefited by immunomodulation. So basically, these alloimmune tests, they don't mean that patient has any disease, you know that. So they will help us to select couple who will be benefited by the immunomodulatory treatment. So that's how we use this test for selecting the couples, and then
basically we are sending blood test only for NK cells.
basically blood test, unless any
Sir, do you
Sir, do you
Yes.
have any experience of using intrauterine HCG with
No.
blastocyst transfer prior to blastocyst transfer?
Anyway, we don't do that, but there are certain papers are there definitely HCG flushing before transfer and showing good results, but we don't do IVF, so that we don't have any personal experience. So but what is your experience?
Sir, we have used in certain cases, but then whether the patient conceived because of HCG or because of the good blastocyst, so that still remains. We have very limited experience. Initially, we read some literature, so we were quite enthusiastic in using it. Then again, we further investigated, then it was not recommended. So we are not as of now using it. So I just wanted to know others' experience. If they have used, then we can further plan something.
Right. So there are papers which are suggesting its benefit, but we don't have experience.
Thank you, sir.
So how many of you are doing IVF? Means most of you are doing
Yes.
IVF also?
Most
All
of
of you.
us are doing IVF.
Yes, everybody.
Yes, sir.
I think all of
Yes, sir.
Yeah. So because so how frequently you encounter RIF? Means what percentage, or rather most of you must be getting already patients who have
Yes, sir.
multiple
Sir,
phases. Right?
Yeah,
sir.
30 to 40% in my practice, sir.
So actually, what usually some of our doctor friends who refer to us, what they have been doing is in the first workup only of these patients who come already with multiple failed IVF cycles, they get them investigated for immunological factor at the beginning itself. So these patients, if they have this test indicating immunological alloimmune factor, immediately the treatment can be done, and the patient comes for IVF very fast. Within a month, can patient come for IVF. Otherwise, then these tests take some time, and also that is one thing that is done by many doctors, and do it as a first line if there are already failures.
Sir,
So
can you please share the list of investigations? Actually, your initial talk I missed.
yeah, I think I can share with Dr. Anuradha if you want, and you can
Yes,
share
sir.
through
Yes,
the
sir. Yes, sir.
entire properly for us.
Please
But
share it in the group so
If
we
the
all get
patient is
the.
if the
Yeah,
patient
yeah.
is a candidate for LIT therapy, sir,
sorry.
then if a patient is a candidate for LIT, then while counseling the patient, how can we say that after how much time you will be able to take the pregnancy in a patient of recurrent pregnancy loss?
No, so see, if the investigations indicate treatment is required, and there is no particular timing of the treatment is not related to menstruation or periods. Any time of the cycle it can be done. And as Madam mentioned, after that 4 to 8 weeks, we have to wait. If the TNF alpha is high, 8 weeks. If that is normal, up to 4 weeks. And after that, the effect is there for almost 18 months. 18 months. So after 4 weeks or 8 weeks, they can start planning pregnancy, whichever way that is required, natural or IVF, whatever is the case. And then up to 18 months, they can the effect is there.
Pooja, can you share a few questions which we have made in our group, which we have sent in the group? Is it possible for you?
Ma'am, I have
I
left
think we
now
have
for
discussed
TV.
all.
1 minute, I will see in the group, na?
Yes, sir. I
Dr.
think maximum
Shashi,
part is covered.
yeah,
I think
I think
maximum part
everything
is
is covered.
Yes, they have asked already.
covered.
I had one patient, sir. I was asking that she had 2 miscarriages, and yeah, as you rightly pointed out, that the CD56 count was low. So maybe in future we'll require her the same
Right. So this is an observation which we have found over
immunomodulatory therapy for her.
one criteria which we use. Otherwise, everywhere they say
Yeah,
high
but
CD16.
they have not done TNF. But they have not done TNF alpha and CD57.
Okay, okay. See,
So,
not all patients will require CD57, but TNF alpha is a good investigation. And if we are thinking about LIT, then cross match is important because that can sometimes rule out that LIT has no role. So then, if it is positive,
yes. Yes.
Sir, we need battery of investigation. What you were saying. So if it is shared with us, we will be abilized.
exactly. We
Sir
just
said he will share with Anuradha and Anuradha will send it in the group.
if you want,
Actually, many of the delegates who are attending the program, they also want the name of the investigations, so that because we'll be maybe 10 or 12 of us will be able to know, but many of the delegates are asking this.
okay, so which group I don't know, or I will share with Dr. Anuradha in our.
I will share, sir. I will share.
Okay,
Yeah.
okay. Then we'll share in our groups. Okay.
Sir.
Sure. I think
We have covered maximum part, sir.
Thank you so much, sir.
yeah, I
Thank
am.
you so
Can I
much, sir.
go?
It's an enlightening talk. Yeah, you are missing the movie.
Sorry.
So much.
He has joined from movie. Dr. Pragya, she has
My
joined in
husband is
between the
calling. Where
movie.
are you?
Acha,
Bye.
that shows the dedication, I think. So
Dedication, yes, yes. Yeah.
Thank you,
Thank
sir.
you, thank
It's
you.
an interesting topic
Thank
by you, sir, so nobody
yeah,
wants
so
to
this
miss.
is not a difficult subject as such. Only we have to think about it. Keep our minds open that this can be there because I am sure many times all of us have some patients like this that if we see them in the waiting room, we feel they should not be there and they should go to my competitor and not to me because you can't do anything for that patient. So some patients will be there like this who may benefit or who will benefit with immunological treatment. So it
Definitely.
is your open mind that will help them. So it's not particular treatment as such, but you see, passive immunomodulation can be used. But we get many times patients who have been given all passive immunomodulation, still they don't succeed because the basic cause is the lack of protective antibodies. Or so active immunomodulation becomes important for these patients and followed by passive immunomodulation. So I think
Sir, how you prepare for lead therapy, sir? Like from the patient husband's sample you take, how much blood and how you prepare?
so we have a process. Actually, this that's what our main patent is about, the process patent. So that's why we have certain restrictions about sharing the details because that's why we haven't
Okay,
started
okay.
training or anything. But time will come, so that will be there. But at least at present, it's a particular protocol, particular cell count. So everything is the particular.
You are preparing by yourself.
There are certain
Okay.
manual steps which are important because this should not damage the surface antigen, which leads to immunomodulation. So therefore, see the process is very important. See, LIT is not just lympho. Many doctors tell us कि lymphocyte ही separate करना है ना तो उसमें क्या है? So, but that's not the way because there are some small amount of platelets are there, small amount of RBCs are there. So internationally there are standards or particular reference levels that it should be below this and more than that. RBC should be below this, platelet should be below this. So all that has to be properly tested and only
Prepared.
because it's not the same, it's affecting the immune system. Though it is a very safe treatment. I think safety part was not discussed, but I will like to share that it is a very safe treatment. We have done, as I said, more than 4,000. So there are no anaphylaxis, no severe allergic reactions at all. It is not an immunosuppressive treatment. It doesn't suppress immunity. It just alters immune response. So there's no immunosuppression. In fact, we don't require also. It doesn't have any long-term effects because immunotherapies are usually associated with certain long-term effects. Two most important are autoimmunity and graft versus host disease. So these two things are not seen with lymphocyte immunization therapy. There are studies, international studies, where patients were followed up for many years after LIT. There is a study of 4,500 patients, and there is no increased incidence of autoimmunity or graft versus host disease. It is safe for baby also because it's given in pregnancy, and there is no increased incidence of thrombocytopenia in the baby. They say some antiplatelet antibody. Nothing like that has been seen or shown. No IUGR or no other effects on the baby. So it's a safe treatment. That is for sure.
Thank you, sir. Do you see
Thank
any,
you,
like
sir.
in earlier books, tender loving care, it was the only treatment available to increase the
That is still there,
immunomodulation.
but that is still there. You can't escape. You can't escape. TLC has to be there. So patients who you don't know. See, sometimes we get patients who have multiple IVF failures, 4, 5, never conceived. We find immunological factor, and after that treatment, they just conceive naturally. So we have
Yeah.
many this that because that was the only factor. Otherwise, everything was normal. So TLC is always required for these
First
patients.
thing, yes.
So that I think you are all are good at it, but then goes beyond that. So when we require intervention,
Yes. It's a new thing. Like we can offer our patients to increase our results.
definitely. So that
Yeah.
is
Thank you very much, sir. Thank you.
Thank you, sir.
yeah.
For,
No, no. Thank
and
you
you
so
have
much for
answered our all
from both
questions
of us.
very patiently.
No, no, no.
We are still,
It
matlab,
was
have
an
many
excellent
questions in
talk,
our
sir.
mind.
It was an excellent, insightful talk, and I think there are so many unexplained cases, and at some point we need to have some answers for them. And
Yeah.
exploring immunological cause is one of the way we can go about it. So
Yeah.
thank
Very
you,
nice
sir,
and
for your
wonderful lecture,
insights.
ma'am.
Definitely, because we get patients from Raipur, Bilaspur. We have a center in Nagpur. So once a month we go there to do procedures, and we have been getting patients from Chhattisgarh area for more than 2 years. The center is there, and so once it is investigated, they just come. I think it's 5 hours or something. I think Nagpur, but the thing is important to think about it. That's what I always tell. If you think about it, then you will look for it. Otherwise, you won't.
Actually,
So that's
thank you so much.
Thank you, sir. Thank you
okay.
very much.
Yeah, I think Dr. Mugdha is, I think, still tied up, but from her side also, I extend thank you, sir. Thanks to all of you, and of course, Dr. Talwar sir for this allowing this program, and ROGS and Chhattisgarh chapter, Anuradha madam, Monica madam. So I think thank you so much, and all of you, the chairpersons and the doctors who are attending. I think it was a great opportunity for us to interact with you.
It
And
is a
anytime
great
you have
opportunity for all of us, sir. And on behalf of Chhattisgarh chapter of IFS, I extend my warm gratitude and thanks to our esteemed faculty members, Mugdha ma'am and Mohan sir, who have graciously shared their expertise and time to enlighten us. And I'm sure that their insights will be invaluable in enhancing our understanding regarding the management of recurrent pregnancy losses. And to all the participants who have participated in this panel discussion as well as as chairpersons, I am delighted to see the enthusiasm and sharing their insights. So I am thankful to all the panelists for very interesting and interactive panel discussion. And it was a great opportunity for all of us to discuss these problems with sir and ma'am. And thanks a lot, our academic partners, Corona, for providing us the digital platform. Thank you very much, sir, for both the lectures and for answering our all questions. And still many questions are in our mind.
so
But
you
we will
you
remain
have our
connected.
numbers. You have our numbers. You can call up or message anytime. Don't worry,
Yes, sir. Yes, sir.
because we don't do obstetrics, so we have a lot of time. You know that. So therefore, we do only reproductive immunology. So that is our passion. So anytime, just send a message if you have any queries anytime, and no
Sir,
problem.
because immunology is a thing, in each book we got a one chapter for immunology. Can you suggest one book which we can read and we can get a wide knowledge of immunology through your experience? Because in every book, there is one chapter for immunology.
So it's very difficult actually. That's what we found, and so therefore
We are
even
dealing with many patients of this recurrent pregnancy losses or recurrent implantation failures. I think everybody in the group wants to get something which is available and which is if we read that book and we can get a good knowledge of things what is happening nowadays, and because when we were students these things are not like that. And there
Exactly, ma'am.
every year there is some upgradation in the immunological part.
Definitely, definitely.
Yes, yes,
Actually,
ma'am, definitely.
you are absolutely right. We are actually starting a newsletter, I think, related to reproductive immunology, means one recent paper, one basic, then one case study. So like that, 4 topics will be there in each every week. It will be already 15 days, I think. So to give more information, because what you're saying is right. There is no book actually. If you go and read immunology book, that is too immunology,
That is
and that is very
too detailed.
basic immunology, and there is nothing related to reproductive immunology as such. And they wanted us to write that book, but it was for us also difficult. Our book has one section on immunology, reproductive immunology, and one section on lymphocyte immunization therapy. That's all. But still, we have specific practical things only. Even in the immunology part, we have addressed. So means what is HLA and what is so all those things.
If it is a
But otherwise it's difficult, and we can keep on sharing these any more information or about that is
yes,
possible,
we will
but
remain
book-wise,
connected, and
it's
we
very
will always we
book-wise it's
can
difficult.
disturb you in your.
No, anytime. It's not disturbing. Dr. Mugdha and me, anytime you can always message her or me. No problem. You can call up also. Yes, no problem. Okay. So
Thank you, sir. Thank you. There is no words to say you thanks. I think this is only expression. Really, I am grateful to you, sir, to clear all the doubts, and all our Chhattisgarh, Bihar, and Odisha chapter all will be benefited by this talk, sir.
Sure.
Thank you.
Thank you.
Yeah,
Thank you. Thank you.
and on
Thank
behalf
you.
of Mugdha also, thank you so much.
Thank you, sir.
Dr.
Thank you so much.
Anuradha. Thank you,
Thank
Dr.
you, ma'am.
Anuradha,
Thank
and
you.
all team, everyone, for the opportunity. It was really very nice and very informative. Thank you.
Thank you. Thank you, sir. Thank you,
Okay.
ma'am. Thank you.